I'm Charissa, and Ilaria and I will do a presentation. We originally we did this together with another ePAG of ours, Vieira, and we also sent it forward for to our own, the rest of the other ePAG advocate members in our ePAG. We are from ReCONNET, the ERN, and that is the connective tissue disorders and musculoskeletal diseases. Now, to give you a background, we did our good practices based on the patient involvement in identifying unmet needs on clinical patient guidelines. The duration of the project took about 4 to 6 months. It was a publication of state-of-the-art on clinical practice guidelines, and it was, I'll give you a background. Originally in the ReCONNET steering committee, there was a discussion, and it was decided that we would publish a narrative review of existing clinical practice guidelines, or CPGs in short. And also, I will explain this later, perform a state-of-the-art CPGs per disease group. During this same meeting, there was a proposal made by the ePAG advocates in steering committee to identify the unmet needs in each disease. The clinicians had further decided that we as patients were allowed to draft the papers and specifically write the patient's unmet needs of each disease. Later in the year, and some papers are still going to be published, but almost all of them have been published in the BMJ RMD, that's rheumatological papers, open. To give you a background of our ERN ReCONNET so that you can follow us a little bit further on, we have 3 pillars in ReCONNET, or 3 arms, as we say. The rare connective tissue disorders, which are the systemic sclerosis. MCTD is for mixed connective tissue disorders. Idiopathic inflammatory myopathies. APL, or antiphospholipid syndrome. UCTD, unconnected connective tissue disorders. IgG4 related diseases, and that is an autoimmune immunoglobulin G type disease, and relapsing polychondritis. These are all rare diseases. The second arm are complex connective tissue disorders. Some of these diseases are in some countries considered rare, in other less rare, or just complex, but they are included. And the systemic lupus erythematosus, or we just say lupus, and Sjogren's syndrome. And then in the third arm, we have hereditary connective tissue disorders, where the Ehlers-Danlos disorders fall under. Our ePAG structure is, we have 1 representative per disease, a representative per pillar. For rare, complex, and hereditary will also represent the whole pillar, and these representatives will also be members, or were allowed, or are part of the steering committee. Then we also have to manage the whole ePAG, 1 senior and 1 junior coordinator. And then as well, we have 1 member and 1 alternate participating in the steering committee from the ePAG. So this is our ePAG. So you can see some of the faces. You can see Ilaria, who will also, she represents systemic sclerosis. We have Vieira. We have 2 new ePAGs, Eve and Sander, who did not participate in this project as they are just new. Sander just joined last week and Eve this week, and we have not even finalized everything. Lisa Matthews, just like Vieira, she was part of the project to help identify patient representatives for the disease. But for others, as undifferentiated connective tissue disorders and IgG4, we have yet today to find somebody to represent. Then also we have Alan Cornet for lupus, and Ana Vieira. She could not be here because she is following a course in Portugal. She is also the representative for Sjögren. Now, only with the hereditary connective tissue disorders, Jürgen and myself are the representatives. There are 2 here. There are more than, there's actually 14 types of EDS. One is represented in another ERN, and there's 13 represented in this ERN. And we really need 2 patients advocates. And for the steering committee members, I'm the patient coordinator for EDS, and I'm also the steering committee members. Anna represents the complex connective tissue disorders, and Ilaria the rare connective tissue disorders. Jürgen and Ilaria are the senior and junior coordinators who manage the whole ePAG. Now, the situation before when the whole project started. The purpose was that the CPGs, or the clinical practice guidelines, would be identified. And the problem was that only 4 of the 10 diseases had previous CPGs, which were systemic lupus, the inflammatory myopathies, systemic sclerosis, and Sjögren syndrome. The other 6 conditions, they did not have any existing CPGs and or recommendations. So each of these working groups, the clinicians and the ePAGs, had to review these as well, look in publications, see if there was anything available, and make recommendations. This would also be a first. Now, why a first? And what do we mean with a first? In the rare connective tissue disorders, there were no papers ever been published before. That included any unmet needs and taking patient perspectives into account. So, and also originally clinicians were the ones in charge of performing the literature review and drafting the papers. So this holds a whole new situation also for a lot of the members of the ERN. The ePAGs, as I said before, were asked to be involved, but in the steering committee, the advocates, we were a little bit also involved in the reviewing the whole process and to represent the patient representatives' perspective, as it may be beneficial to include patients' unmet needs in the papers. When we said this, we asked this question during steering committee, and to our surprise, the coordinator and all the members of the steering committee agreed, and they went a step further. They said, well, you should not only be involved, we find that you must also identify and draft a patient unmet needs on the CPGs and co-author the papers as well. So every patient advocate in our ePAG would have the chance to co-author. So then the ePAGs in the steering committee, we were asked to also review the patient's contributions, and we were recognized as co-authors in all the other papers. So there was not an ePAG patient advocate for all the diseases, and that would cause a problem, and we were asked to find a patient representative. And for the diseases where we did not find one on time, the unmet needs sections were actually developed by either Ilaria, myself, or Anna. And the clinicians never had any experience, or most of them in the ERN had any experience to work with patients on this level. So it created a whole new situation where we had to all learn from. Now, as I already mentioned, but we wrote it down twice, that it's very important to know that a lot of the diseases did not have any pre-existing documentation. And now I ask Ilaria if she would take over.
Yes.
Ilaria,
Ilaria,
you have 10 minutes to, if you have 10 minutes if you want to do 20 and 20 questions, 20 presentation, just for you.
Okay.
You can go a little bit further, it's okay.
I will go quickly. through the contribution to patient engagement and improvement of care. Here is where we really started working. We had to collect the unmet needs of our communities. So we had to collect 10 diseases, unmet needs. And
would you like me to share the slides for you?
I am sharing, you can't see? Can't you see?
So we can
Oh
see.
yeah, now I can see.
Okay, now?
Yeah, now it's coming.
Okay, sorry.
Yeah.
So, perfect. So we had to search in our communities all over Europe and then select the unmet needs of patients for the 10 diseases. And it was very hard, as Charissa said, and it was also very interesting because when I compare an unmet need of a patient with systemic sclerosis living in Cyprus and the unmet needs of patients living in Norway, wow, there was a great difference. I knew I would find a difference, but it was a really, really a big gap. So we understood in that moment that ERNs were the place to be. And we needed to raise the level of the Cyprus patients to the level of the Norwegian patients. So we tried to select the most important unmet needs of the communities. And then we had to discuss them with our senior and junior disease coordinators, I mean the clinicians. And what came out were transversal unmet needs that are common in all the 10 diseases. And we decided to start working from those transversal unmet needs. So we brought the unmet needs first to higher standards of care, and then decided to identify at least 3-4 unmet needs and start working from them. We started working on the therapeutic education because among the clinicians in ReCONNECT, we have experts in patient educational therapies. And at the beginning, it was not that easy. We had some argues with the clinicians, but then went really well. We deliver a survey on the patient education. We, as ePAG, spammed it all over Europe through our channels, website, newsletters, and social media. And then we already have the results. We asked the clinicians to provide us the results in order to translate them once again in all national language and get back to the patient that provided their answers to the survey, because these are 2 unmet needs in one. So the therapeutic education and get back with result to the community of patients. And then we will start working on the certification of websites that provide right and scientific information, like this website is a certified website. And we also believe that patients need to know what we have done, and we need them to know what happened in ERNs. So we decided to work on lay versions of the narrative reviews. So let me just have you an idea of our creators. We are very, very proud of them. You see, systemic sclerosis is my disease. So this is the state of the art of clinical practice guidelines for systemic sclerosis. You see highlight the names of the ePAGs that reviewed the papers. So Charissa and Anna and me, of course, and I worked on the patient unmet needs. Each of us decided with their respective disease coordinators how to work on the unmet needs, because it's part of a global project. And I decided that I wanted the unmet needs that already had a publication, because I wanted scientific community not to say, okay, these are the unmet needs of patients, they always complain themselves, they are always unhappy. No, I wanted them to know that those unmet needs were already somewhere in PubMed. I made my review, literature review, and they have references. So now these unmet needs must be satisfied. Okay, this is Sjogren's syndrome. Anna worked on it. We also have lupus, antiphospholipid. So for lupus, Alain worked on it. For antiphospholipid, we helped the patient in working at. And EDS has a different story. So I would like Charissa to take again the
reins.
Yes, and spend a few
Yes.
words on it.
As I previously also mentioned, there were a whole bunch of conditions or diseases that had no existing state-of-the-art or clinical practice guidelines. So we had a slightly different task, and Jürgen and I, we approached. It was very much focused on the patient unmet needs, and as one of the unmet needs is that there is no clinical practice guidelines or any patient pathways or anything available at all. So Jürgen and I, we approached also our patient community and or wider patient community, and then we presented with this paper. And it was for us a very important part, because there are actually no doctors that can follow us up, and it was also very important that this was published in RMD Open, because a lot of patients, there are no physicians, specialists, or clinicians or geneticists available, and we also had to involve the rheumatic community to start helping our patients in all of Europe.
Okay.
Ilaria?
Yes. So now I go through the what led us to the success. First, we started having a strategic vision, but for long-term impact, because we wanted to deliver something that will give the results through the year in the delivery of care, of course. And we have to explain to clinicians that they would benefit by networking with patients, because as Charissa mentioned before, it was the first time that the patient's views on unmet need were included in such documents. Not the first time that unmet needs, but the patient view on them, which is quite different because we brought our perspective. And honestly, for some of them was the first time of such a collaboration, but we have a very good and sensitive ERN coordinator. Maybe because of her experience, she works in lupus with pregnant women, so she's very aware that involving patients from the beginning can make the difference. So she pushed with us to make her colleagues understand that such an involvement were crucial. And working very hard on the same targets led us, ePAGs and clinicians, to have a mutual respect. And this was the cornerstone that made everything easier after that. We realized how patients with rare conditions, or maybe with very rare condition, need to be trained in advocacy problems like Eurordis does, but also EULAR, which is the European Society of Rheumatologists. It's our society, which has a very strong representation of patient, which is PARE. They should work a little bit more for patients with a rare condition instead of just rheumatic diseases. And here what we have learned. We learned that an active participation led us to fully represent our communities. We engaged with them, we gave them feedback, and we were really bringing their voice into ReConnect, and was not only our perspective and our voice. And this, what I said, the cornerstone, the mutual respect, allow us to be also not only active, but proactive, to propose, to say, hey, we would like to do this, we would like to do that. And they were hearing, they were listening to us, and they were ready to work, to engage with us. And it's also happened because we try always to be as diplomatic as possible and in a professional way. The communication is not among patients and clinicians, but among ePAGs and clinicians. Also inside the ReCONNECT steering committee, we are at the same level. And this is quite important because we must act like professionists. So it was very difficult. It was not easy to work at the guidelines, to make the review, and we learn a lot. So I am very grateful to this experience. And we think that focusing the attention on the unmet needs and on the patient views on the unmet needs made them be acknowledged by the scientific community and made the clinicians happy because now they have some publications more in PubMed, and we are happy because we have our views in PubMed. So we are all happy now. And it is also the proof that the involvement of patients from the beginning can make the difference for us and from them. But we also have to face a challenge, which is, as Charissa mentioned, the disease that were not covered. We were very happy to contact single patients with those diseases and try to collect their unmet needs. Some of them really didn't know what they were expected to give, what we were asking, really. And this is the reason that make us say, please improve the training, the advocacy for those patients, because we need their voices, because they are, the less they are, the higher voice they should have. But anyway, I think that there is also a bias, because despite the fact that we put all our enthusiasm, we can't know what living with those conditions mean. So I think there is a little bias. But anyway.
Shall we open now the floor for questions?
I have another.
Okay, go ahead.
This is the proof of concept. So we now are happy to replicate the experience. And we met 1 month ago in Pisa for our annual meeting. And the clinicians were talking about working on patient pathways. And they were very happy. And we rose our hands and say, hello, we are working on, we have a working group in Eurordis led by Matt Johnson on clinical pathways, patient pathways. Other ePAGs in other ERN already did and shared their good practice. So maybe we can work together. And they say, no, start working you. We need your inputs. So it's useful if you provide us the results of your pathways before we start working on it. And I think that without 1 year of collaboration, we would not have that answer. Stop. Go on with the questions.
Thank you, Charissa. Thank you, Ilaria. Any questions for them?
Yeah, can I just say, I don't know if anyone else is trying to jump in. First of all, I'd like to thank you for, I think, was actually a fantastic presentation. Not just the presentation, but the topic. And I'm actually scratching my head and thinking we should really have had the whole call this time for this particular topic, because actually I think what you've done is fantastic. I would like to repeat that in our own network, And there is so much more that I want to know than is possible to present in this short presentation. So I hope that you get the chance to represent this again in Bucharest, because it deserves a much wider audience than you can get in this. And really, bravo, I really enjoyed the presentation, and it's exciting to think about what you've achieved. And I feel a little inadequate coming up next, that I have to follow that.
Well, thank you. I do have to also recognize that within our ERN, they are very open to patient participations, and we get a lot of opportunities. And we are very happy to be part in the ReCONNET. At first, it seemed like everything was going so slow for us, and then all of now it's going so fast there, and we are really we had to show them what our worth was, but we have become really equal partners in our ERN. So thank you for the compliment, Russell.
There was someone else who wanted to ask a question.
Just quickly, Alain here. I'd just like to make a comment. I was part of the exercise being in the same ERN, but what I would like to stress, and that's of relevance for I think the other ERNs, is that one of the opportunities we have through an exercise like this one is actually we had patient unmet needs in PubMed. Now, it's not the publication. Well, it is, but it's not only that. It's the fact that when people do a research later, that's where they go. And that means that those unmet needs, they're not published once, they are published multiple times, because people go back to PubMed to make research, and they're going to find those comments time and time again. And I think that, frankly, that's one of the priorities that we can achieve through working in the RN, is to have some patient views included in articles that get in articles that are going to be on PubMed in such a way that they get retrieved later on. And that's something that's of high value, and it's worth all the efforts which have been done for getting that results through.
Thanks a lot.
I'd actually like to sort of follow on from that. I'd be really interested, and I don't know whether this is something that perhaps we'd speak at another time, but I'm really interested in how you documented in PubMed those patient unmet needs, sort of, you know, the type of approach that you took, and what kind of documents you came up with, or was it just that those views became part of those state-of-the-art guidelines? But I agree it's really important, so I'd like to understand more about how you documented that.
I also, following up on that, I have another question for you too. How Ilaria was mentioning that there were very different unmet needs varying from country to country. So how did you come to an agreement on what to keep, kind of, or what was the standard?
Okay, they were quite different because of the regions. We tried to keep the unmet needs that were shared by most of the countries, of course.
And with EDS, what I did was we mentioned that there were also cultural differences or differences in country to country, as there was no care or anything existing in those countries. So I approached it on a more general way. To be clear, the unmet needs sections are completely written by the patients. So in the EDS part, the unmet needs sections is like almost 2/3 of the paper. So it's very important that we were recognized, and also that we had the chance to write it as well. And they did not interfere, and the only changes that were made were maybe grammatical or some spelling, but we had completely the free hand to do it.
If I can just complement that, because I think that the way unmet needs were identified varied a lot depending on what was existing by the various pathologies. And so in some cases, at least if I can, the example of lupus, we could rely on existing patient panels which were conducted by organizations where people had voiced what their needs were. So we could use those panels, which did not have the credibility of an external publication, but when put together, we're getting there. And then we got that reviewed by an equivalent to a CAB, a community advisory board. And I think community advisory boards are a great source for understanding unmet needs and for giving them the credibility they need. They went through the board of Lupus Europe to validate also there. And then finally, we confronted them with doctors and we said, listen, this is what we see as being the unmet needs. Now, if you think of the patients you have in front of you, does that make sense? And it was amazing to see that everyone came back and says, yes, it does make sense. I can recognize what people tell to the nurse when they arrive. I can recognize what they say to the social workers when they arrive. I can recognize the need. And so all these small items, none of which in itself was sufficient to call it an official unmet need, when put together, make it definitely pass the cut. And now it has the credibility associated with it.
Yeah, and we wanted to keep separate the clinical unmet needs from the patient unmet needs, because sometimes they were tried to combine, but we want to keep them separate because these are two different fields of action.
Okay. Any other questions, comments?
This is Lisa. I just wanted to say that this is such good work. I'm really, really impressed. And of course, it would be nice to duplicate it. And it would be very good to have sort of a list of first steps, for example, how you did the initial surveys, also that you got a budget for the translations, etc., because that would facilitate it for other ERNs, since, for example, in my ERN there is no budget for translations. So it's very, very good to just to put this down in writing, how the initial steps were taken, because then it can evolve. But just to show how much support you need initially from the clinicians, the various meetings you had. I suppose you work with Matt also, but that would help because...
So maybe, so we're going to upload the good practices. They have, all of them, they have fill in a template. We're going to upload them to our website, but maybe Charissa and Ilaria, after this call and this suggestion, you might want to go through your template again and maybe include, because maybe include these first initial steps because they're not there. There's some explanation around the situation, the initial situation, but maybe you want to complement it.
Anyway, no money. And no money.
No money.
No money.
But you did the translations without money.
Yes.
Yeah.
We had to be very creative.
I would appreciate that. Yeah, but I mean, still, you know, because it's sort of easier for us then to start up in the same manner, kind of.
Yeah.
So it would be a great help.
If I can give a tip, deepl.com, DEEPL.com. If you, it's a...
Okay, we already use that.
Yeah.
And in in ReCONNET, we have not only clinicians, I don't know, maybe also you, but we have methodologists, we have experts in health economy, we have experts in law, in legal issues. So not only clinicians, we are supported for the surveys by methodologists. Yes, and this is quite important because we don't think, okay, we want to know what the state of the art on something is. No, we have methodologists that say you can say that, ask this one. It's really teamwork.
But then, Charissa, Ilaria, it's good that you add that into your good practice.
Yes,
that, you know,
absolutely.
those you had those resources. You just don't, you know, because you have them, you don't realize how important they are. But just put them there.
Absolutely.
The initial steps. That's good. In the maybe in the initial situation section.
Yeah, with pleasure.
Can I also say, I think first of all, we need to think again a little bit, maybe, Inez, about the template, because actually we're asking them to put lots more stuff in, but of course the template is necessarily a very limited space with a maximum number of words, etc. If we're not careful, the only way to get it in is to put it in as bullet points. So I think we need to have the possibility to link from the template so that people can look at a summary version of the best practice and get a flavor of it. But then for something like this, for me, and from Lisa's comments, I think she perhaps feels the same, I'd like to dig much deeper into this, because I want to suck everything I can out of this best practice and develop it for our own network, because this is something that is really needed across all of the networks. And I think this is a perfect example of best practice. For example, it seems that there have been quite a few papers published in different conditions. I'd actually like to read all of them. I know nothing about those conditions, but reading about how they've approached the unmet needs in different conditions helps me to think about how I might make that approach in the conditions where I'm responsible. Now, how do you do that? It's going to have to be some sort of shared space that is linked from, we may need a series of links so that you can dig as deep as you want and however much time you have. But for me, I want to spend hours and hours on this, not just a short amount of time, because I think we need to develop it in our network as a project.
Okay, then maybe you can contract Charissa and Ilaria as consultants for ERN. No, I listened to what you're saying, Russell, and we can have another.
And also, I mean, as you were saying, Ines, to contract, I think if people have been through a journey like this, if it could be maybe on a couple of instances, maybe that we could maybe probe their minds and ask them questions, so in a way, a sort of short meeting, just where we can really talk, so that we don't misunderstand things, because even if we spend hours and hours on all these fascinating documents, we do need the sort of human touch, and you're very good at explaining things, both Ilaria and Charissa. So if we could just have time to ask you things.
We will have them in Bucharest, so you'll have time for questions in Bucharest. Now, Russell, yours.
Yeah, can I quickly add, I think actually this could itself make a publishable paper. It's something you might want to consider, Charissa and Ilaria, that together with your network, you actually publish a paper on the general approach you took.
It's funny that you mention it. There is a big EULAR coming up in Madrid, and because especially the unmet needs for EDS are they're tremendous, and there are no doctors and there are no centers. And I actually just wrote a abstract with Jürgen's help about this, and also about the unmet needs. And I hope it gets accepted at EULAR, because that will give me a platform to actually go further than these papers. And yesterday evening I had rare disease network on the Flemish side, which are basing on a couple of proof projects starting up based on the ERNs, where as well EDS is included, and they actually are picking up on our papers, and because we wrote the unmet needs, so it was a very